So, dear colleagues, hi. So, my name is Alexandre BELOT. I'm a pediatric rheumatologist in Lyon. And today I'm going to present to you the Still disease complication, some update on some complication that has been discussed recently. So first, just to introduce the topics, to mention that now we will use Still disease for systemic onset GIA, which is a way to harmonize the naming of the disease between adult onset Still disease and systemic onset GIA. Actually, a global task force across press and EULAR have worked hardly to look at different papers, and it turns out that there is no clinical, biological, or outcome reason to make a big difference between systemic onset GIA and adult onset Still disease. And it will be easier for the future, especially in the perspective of treatment. So let's discuss for the talk about Still disease with a focus on complication occurring in children. So some of the statement went out during the discussion and the presentation. So as you may know, when we discuss about Still disease, we are scared by macrophage activation syndrome, and we used to screen for this disease. But what has been recently identified, it's also some lung disease associated to Still disease that deserve a very cautious screening. And so the mass could be considered in patients with the persistent fevers, splenomegaly, increased ferritin, and low numerous that are also evocative. And I think the decrease of fibrinogen is one of the most important things in the context of hyperinflammation that make you think about this complication. So the treatment of MAS include high dose of steroids, and you can also add a couple of medication, including T-cell inhibitors like cyclosporine, but also some global cytokine inhibitors like anakinra for IL-1 RA blockade or interferon gamma blockade, and possibly also the JAK inhibitors. So let's discuss about lung disease. So within this task force, it was recommended to look with high resolution CT scan as soon as we have a start of lung symptoms. And may I start with a clinical case to illustrate this purpose, to say that here it is a young boy that started a Still disease before the age of 2. He suffered for fever, myalgia, typical rash, initially with a hyperinflammatory syndrome. And he was initially treated with non-steroidal auto-inflammatory drugs for a short time. And he presented hypereosinophilia macrophage activation syndrome in the context of viral reactivation. And at that time, he was treated by steroids, by anakinra, but it was not enough, and he presented some reaction during the time of injection of anakinra. And the same occurs when he went to canakinumab, and actually cyclosporine was introduced to improve the safety of the drug in some extent and the global efficacy of the strategy. Then moving to tocilizumab, this boy presented a very severe reaction with diffuse rash. And before the end of 3 years old, he presented with clubbing and a sensitive hyperinflammatory phenotype and pain in the extremities, looking like here in this picture with the typical clubbing that is usually seen when you have a severe lung disease. And at this time, so the CT scan demonstrate an interstitial pneumonia. And the lung biopsy was done, showing a lipid pneumonia. And here, this is the keywords about this complication. So early onset, severe disease, pseudo-addressed to the drugs and tocilizumab, but not only, also a poor tolerance to IL-1 inhibitors and this typical patchy lung disease that can be quite impressive, and with the unexpected finding of lipids crystals within the tissue. So this entity was actually reported by Vivian Sapper a couple of years ago with the 61 patients with systemic onset GIA or GIA-like symptoms, interstitial pneumonia, that can come up in the context of Down syndrome with a very high increase of ferritin and a lower number of lymphocytes, but no evidence for monogenic disease was found here. What was striking is that most of the patients were before exposed to IL-1 or IL-6 inhibitors, and a little less than half of patients presented a rash due to the biologics. And the outcome of the disease, this is a retrospective study, but this was a lot of worries and concern when you look at the number of deaths in this series, very high due to MAS, due to the lung disease itself, or due to pulmonary hypertension. Another study came up from Rafael Goldbachmanski group and also highlights this same phenotype with this clubbing, which is very, very typical. So look at the fingers of your patients, and the lung disease, also typical with the lipoid infiltrate, and an increase of IL-18 that is as high as we can find in other autoinflammatory diseases, such as NNSC4 gain-of-function mutation. And here, Grant-Schuller adds some information related to the global cytokine profiling of patients with an increase of IL-18, even in the bronchoalveolar liquid in the serum, and also an engagement of the interferon gamma pathways and increase of this cytokine and related chemokines within the blood. Again, no genetic defect identified here. And in the study, Grant-Schuller and colleagues also mentioned how it looks within the tissue with this inflammatory infiltrate that can look like pulmonary alveolar proteinosis and lipoid pneumonia, depending on the case. Some vasculopathy in some cases, and the anomalies at the CT scan showed this patchy and ground glass opacities within the lung. Here, this is the European report from the press mass task force. And in about 50 cases, there is also a chronic persistent disease that was found, an history of MAS before, eosinophilia, which is very common in these patients. And we found again the exposure to IL-1, IL-6 inhibitors, and an increased prevalence of this HLA haplotype DRB1 15 up to 100%. And here it is an interesting information that was pointed out by others just to see across the different studies. You can see the number of people with a systemic onset GIA that develop either a pseudo-DRESS syndrome or lung disease. And taken together, it is about 80% of patients with this specific complication that are positive for the haplotype HLA DRB1 15. And it is also found in other patients, but it's only 25% of other systemic onset GI still disease that are positive for this haplotype. I like this picture from Peter Negrovic that show two hypotheses related to this lung disease. The first is that the drug and biologicals could play a role as an antigen, being responsible for a DRESS syndrome, which is a delayed immune response and toxidermia, very severe, that can be fatal. And in that case, so the DRB1 15 can play a role in presenting the antigen and activate the Th2, the viral reactivation, and then, as we can see in DRESS, promote a severe lung disease, and hepatitis, and diffuse rash in these patients. And if it is the case, we should avoid definitely the treatment and do not introduce again the treatment. But the current hypothesis is the second one, that the drug and biologicals could act as modifier of the T cell plasticity. Because if you block IL-1, IL-6 in the background of still disease, there might be some specific T cell differentiation defect, skewing the repertoire to Th1, Th2 T cells that will then promote the high production of interferon gamma by Th1 by attracting eosinophilia by Th2 and driving this specific lung disease, but essentially due as a cause of this T cell plasticity modification. So in this second case, we should consider how to implement the treatment, but we can keep going with the drug. For this reason, the press EULAR task force mentioned that there is no sufficient evidence to stop the idea of treating patients with IL-1, IL-6 inhibitors. So even in the context of lung disease risk factors, and there is no evidence to stop IL-1, IL-6 inhibitors when the lung disease occurs, meaning that we need to think about something else and use add-on therapy like T-cell driven therapy that could be considered, such as cyclosporine, mTOR inhibitors, for example. Here I just highlight the case I presented to you, because here in that case, we went to JAK inhibitors and stopped the biologicals, and the patients went well, and we managed to stop all biologicals and also steroids, and is now only on JAK inhibitors, and it totally recovered the lung disease. I know that there is another demonstration of JAK inhibitor efficacy in my French colleague from Necker's hospital, but I would say it's only 2 cases, so we definitely need additional information and other reports. Some other strategy included cyclosporine as a treatment, interferon gamma inhibitors, and even in some very rare and difficult, challenging cases, bone marrow transplantation. That here, in any case, it is very important to consider to discuss these patients. They are very challenging, and the RITA network, for example, is a good way to present this case and benefit from the intervention of other experts and colleagues. So now we go back to the hematological complication. I'm sure you're aware of the macrophage activation syndrome that can occur in still disease. It's one of the most severe complications. And if we make some history, so the French group identified here initially possible complication of still disease, which was called juvenile rheumatoid arthritis at that time, that occurs with acute hemorrhage, liver disease, and the neurological manifestation. And in these patients, it turns out that when you treat the patient with steroids, it seems to be beneficial. 2 patients died, and they were not treated by steroids. How can we define MAS? So there was a first work from Angelo Ravelli that shown that there are some specific threshold to help clinicians to make the diagnosis of MAS, but these thresholds are not so helpful in daily practice, considering the number of each items that you need to look at your table as soon as you expect a mass diagnosis. But more recently, a EULAR ACR task force proposed to be particularly cautious in a patient with a persistent fever, elevated or rising ferritin, and also in patients with an increased markers of damage, such as LDH, in patients with cytopenia globally, hepatic dysfunction, and within the coagulopathy also, looking at the low fibrinogen patients that are in the context of hyperinflammation, particularly evocative of mass. Splenomegaly, CNS dysfunction is also important to screen. So taken together, here you have a broad definition of mass. And in the future, I'm sure that some additional biomarkers will help us to make this diagnosis possible. IL-18 that has been discussed, we discussed it during the lung disease associated to STIL, but here in mass, there is also a massive increase of IL-18 in that cases, but also some markers of interferon gamma, such as CXCL9, for example, and all the others items that you may recognize here. So when you are facing to a mass, the strategy is always the same. So think about what can be the driver of this specific disease. Is there a gene anomaly? Is that due to a therapy and in DRESS syndrome? There could be a macrophage activation syndrome in about 30% of people. Infections can be either causal or the trigger of the mass. Hemopathy, cancer, we need to screen cautiously to these possibilities. And inflammation, which is, I think, among the most important cause of mass. We screen for lupus, we screen for STIL disease in all these cases. And here you have the distribution between primary HLH that could be due to monogenic defect, especially of cytotoxicity, and the secondary HLH. Within, we can find a number of different patients. And in each case, the strategy will be really different for the treatment. So when initially it's almost the same for all patients, you start with steroids, possibly with T-cell inhibitors, but then it will be driven by the cause. So we always need to look at these 5 big families of possibilities. And for this, the EULAR ACR recommendation are really helpful to help us to go through this hypothesis. And it was led by Scott Canna. And you see here this hyperinflammation or suspicion of mass. You will assess this using all the markers we described. You investigate whether it could be triggered by something genetic, something infectious, something due to a drug, something due to a malignancy, possible hyperinflammatory syndrome occurring in rheumatic disease. And then you treat the patients. And as you see here, steroids are the best treatment in that case. You can add anakinra or IVIG, monitor, reassess, and then as soon as you have a confirmatory, you can make the good choice across all these possibilities depending on the trigger of the disease. We stay within the hematological complication, and I will just mention this study done by Francesca Minoia, which is, I think, very interesting. So in mass patients, some of them can present with a thrombotic microangiopathy. And that's not so easy to identify because a lot of all clinical and biological overlap exists between these two situations. But it seems that patients with microangiopathy have a higher number of hemorrhage, a lower level of platelet, an increase of the bilirubin. But what is the most striking thing is that these patients can present a renal involvement, of course, and an increase of the creatinine. So if you have a patient with MAS that develop a kidney disease, think about the microangiopathy, which is probably the cause of this complication. So as a conclusion of this talk on the complication, so still disease with this new name will help us to treat the patients equally from children to adults and using probably same protocols, share ideas and experience. And it will be a way to introduce the concept of treat to target within the still disease with real objectives. And the objective are to decrease the usage of steroids. Biological first are recommended within the EULAR press task force and the recommendation that will come out soon. Screening for mass and use of steroids in that case. So if you have some even modest signs of mass, don't hesitate to start steroids. And the screening for lung disease, looking at the clubbing, looking maybe at some biomarkers such as IL-18, and as soon as you have a lung symptoms or lung disease, respiratory symptoms, don't hesitate to do a CT scan. And here, the management is still challenging, so it's important to discuss with colleagues within a multidisciplinary team. And to finish, in case of renal failure in the context of MAS, just think about the thrombotic microangiopathy. Thank you very much, and don't hesitate to reach out the Filière FAI²R if you have some interest in other rare disease video that are available on the website. Thank you.